This is the Society of Thoracic Surgeons Adult Cardiac Surgery Database Quality Improvement Series webinar. We're going to be talking about decreasing blood usage today. On the call with me from the STS, we have Emily Conrad, Leanne Jones, Paul Meehan, and Melinda Offer. All right. I just have a couple of very brief STS updates since this is the quality webinar, and then we'll move into the presentation today. We'll be sharing some blood usage data from the database. And big shout out to Paul, who helped pull that data together for me. So just to run through some important dates, today is our February 19th and the quality webinar. Friday, February 21st, Harvest 1 close. This is our dates January 1st, 2022 through December 31st, 2024. I hope everyone has gotten their data submitted already. If not, good luck to you this week. We were all just saying we feel like this is such a long week. It always seems that way when it's time for harvest. February 25th is our opt-out deadline for Harvest 1. On February 25th also, we will be having our first session of the Data Manager Training webinars. Those will begin at 12 p.m. Central Time. Then March 5th will be our monthly webinar, and then we will have another quality improvement webinar on March 19th. Before I give any updates on AQO, I just wanted to let you know this is hot off the press, the risk model variable chart that was updated to include multi-valve and multi-valve with CABG. That risk model variable chart has been updated and is now posted on the website, hot off the press as of about 15 minutes ago. So I know you guys will all be looking forward to that. So as far as AQO 2025 goes, we will be gathering in San Antonio October 2nd and October 3rd. Congenital and general thoracic sessions will be on Thursday the 2nd. Those will run concurrently. Adult cardiac surgery will be on Friday, October 3rd. We are going to be staying at the Grand Hyatt, San Antonio Riverwalk. And we have a session proposal form on the website. You can find it under the AQO information. Go to calendar of events and scroll down until you get to AQO, and you will find the proposal form. This form is so that we can, if you have any topics that you want to hear about on or during AQO, you can submit that proposal. The deadline for ideas is April the 18th. So again, AQO will be both in person and virtual, and we will be sharing any cost information as it becomes available.
Hi, Nancy.
All right, so we are going to move into the program. But I'll go ahead and I'm going to answer this question first. We had a question in the Q&A. Anita is asking, was I mistaken in thinking tricuspid valve cases were going to become their own risk model like the other valves, or is it now just included with multi-valve procedures? So tricuspid valve cases are not going to be have a risk model on their own right now. Tricuspid valve repairs are included in the multi-valve procedures when there is a multi or mitral valve repair or replacement. And then Amanda is asking about information or links for the data manager session starting next week. And that will come out in the notifications that you get at the beginning of the week. for the webinars. There will be a link sent to your email box. There also will be a link on the website.
Yeah, it's on
as
there.
well.
It's on there now.
Where
Okay,
is
great.
that, Emily? Because I couldn't find it myself.
They just put it up there. It's where all the other webinar links are.
Oh, okay.
They put it up there yesterday, I
Okay.
believe. So if you scroll down to where the adult cardiac surgery database webinars is, it's now listed there, ACSD data manager training webinar. In between the quality improvement one and the monthly webinar one.
Thanks, Emily. Emily also put the link to the session proposal form in the chat for you guys if you need it. All right, so we will go ahead and get started here. So we're going to be sharing some data today on blood usage in the adult cardiac surgery database. This data is isolated CABG data from Harvest 3, and we will be sharing data from 1,030 participants. So here we have the intraoperative blood usage, percent transfusion. This first chart shows that the mean transfusion rate was 27.09%. And you can see that documented there with the red line marking the mean, and with a range of 0% transfusions all the way up to 91.7%. And if you look over to the right, this just kind of gives a better distribution. You can see where the outliers were. So this middle bar here, most of the participants were between 15.3% and 20.4% rate of intraoperative transfusion. In this slide, this shows the intraoperative average units by blood product, and it's kind of busy. I have this broken out later, but the main thing I wanted to point out in this slide, the dark blue bar is your packed red blood cells average. And so that, as that goes up, the orange bar, which are your platelet units given, those trend down. You can see with the yellow trend line. As the blue bar, red blood cells go up, the platelets, the orange bar, those come down. This is intraoperative red blood cells average units. So on average, sites are giving 1.4 units intraoperatively with a range of 0 to 3.3 units. Then over to the right, intraoperative platelets average units. The average for platelets is 0.76 units with a range of 0 to 5.75 units. On this slide, we'll start with intraoperative FFP. So on average, sites give around half a unit of FFP with a range of 0 to 3.18 units. And then you'll see here your cryoprecipitate average units. So sites on average give about 0.3 units of cryo in the operating room with a range of 0 to 3.87. Here we're looking at postoperative blood usage. So the percent postoperative blood usage, or the percent transfusion, sites on average are transfusing their patients postoperatively around 30% of the time. And the range there is 5% to 94%. And you can tell when you look at this graph that 94% is quite the outlier there. So your average is around 30% transfusion rate in the postoperative period. And then again, over here to the right, this is just displayed a little differently. You can see that most sites are transfusing postoperatively between 22 and 30% when you look at these two middle bars. So for postoperative transfusions, the relationship between the increased packed red blood cells, as those go up, there really is not much of a relationship between the platelets, FFP, and the cryo that are given postoperatively. And so we'll break that out by product. So for postoperative packed red cells, sites are giving on average about 2 units with a range of 0.6 to 6.5 units. And then for platelets, sites are averaging half a unit. And my range isn't showing up there. The range there was 0 to 3.1. Get that corrected. So for FFP, so the average number of units transfused of FFP is around 0.6 units or half a unit. And then the range is 0 to 5.4 units. Then we have our postoperative cryoprecipitate. So on average, sites are giving 0.3 units of cryo with a range of 0 to 2.6 units. So we also wanted to look at the effects of blood usage on complications and post-op events. So this slide here depicts perioperative blood usage versus complications. And so perioperative blood usage, this includes patients that had at least 1 unit of blood in their hospital stay. And you can see that as blood units, and this is all products, as the transfusion of blood products rise, you can see that complications increase by the yellow trend line there. So where we saw this affect the most for perioperative blood usage and the effects on complications was with reoperation for bleeding and with renal failure. So here, patients that had any blood transfusion, there was an increase. There was an increase in reoperations for bleeding and also an increase in renal failure. We also saw an association with increased blood units given in the perioperative period on operative mortality. So perioperative blood usage did not have that great of an effect on our anticoagulant bleeding events or our postoperative length of stay. And again, this is perioperative blood, meaning intra or post any transfusion. Oops. Oh, there were more slides there. All right, that is all that I have for today. We do have more data that we can present on another call. We can answer questions. You can raise your hand, use the Q&A function. Let me see what we have here. So Sarah, Sarah's asking, is that 27% of all cases had intra-op blood? Yes. 27% average. It's the average of all cases or of all sites. The average rate of intraoperative transfusion was 27%. Then Gina is asking in the chat, is there a target for this PI project? We don't have a target for this PI project because Carol and I talked about this. This is pretty site specific. And any improvement that you can make in your blood usage is going to help the patient. It's going to promote patient safety. So if you move the needle in any way toward the better, you're going to be improving your patient outcomes by that. So we decided not to set a specific target. I know on our calls that we've had from sites who have had successful blood usage projects, they have talked about 0% transfusions. So that is a pretty lofty goal for some sites. So we opted not to set that goal for everyone. But obviously, at your own site, you can set whatever target that you would like, whatever works for your site. Beth is asking, what are the numbers across the bottom? So the numbers across the bottom are just the numbers of participants. And Chris is asking, is this data from all sites? I may have missed the time frame and where this data is coming from. So yes, Chris, this is all sites that participated in Harvest 3. It's 100 or 1,030 participants, Harvest 3 data, and it's isolated cabbage only. And yes, Beth, this is over 3 years. The time frame for this data presentation was 3 years, so Harvest 3. And a hospital did give an average of 6 units of FFP. There were some sites that gave very little to no blood products. In this harvest. And yes, Sarah, sites are different from cases. So so Amy's asking about cost. And so obviously cost is a very important factor when we're talking about blood usage. Second only to patient safety. Blood transfusions are expensive and they can increase, as we've seen, increase complications So there is an increased expense. I believe in past data that I've read, not this particular data, but past data that I've seen, you may have an increased ICU stay. So there is definitely an increased cost to, with giving blood. I don't have any exact numbers on that. We do know, however, anecdotally, that lowering your blood usage will lower your cost. That is why a lot of hospitals and health systems across the country have blood utilization projects. So especially for cardiac surgery. I read one time that cardiac surgery was the number one user of blood products in the United States. That was from a long time ago. I'm sure it's still probably the case. But I do not have any exact numbers on cost for this data. If a patient is transferred, this is from Carla. If a patient is transferred to another facility, do we count transfusions before transfer?
I can take that one.
So, yeah.
So
Take
it
that one.
sounds like, Carla, that you're talking about a patient that is transferred to another acute care facility. So that's what I'm going to operate off of. So when a patient is transferred to another acute care hospital, then you are going to be capturing pretty much everything that happens at that other acute care hospital that you can capture. So you'd want to capture the blood they got there, the vent hours there, ICU time there, the complications there. So hopefully that. So if you would so for your transfusion question, if they had transfusions after they were transferred to that other hospital, then you would want to capture those in the post-op transfusion section in the data collection form, because the patient who goes to another acute care hospital is technically not discharged until they're discharged from that acute care hospital that you transferred the patient to. I hope that makes sense.
That made sense to me. Thanks, Melinda.
You're welcome.
All right, so Morama is asking about the correlation between blood causing the re-up for bleeding, or re-up for bleeding caused the blood usage. So it's like, which came first, the chicken or the egg? So with every unit of blood transfused, we see an increase in blood usage. And so it could be either way. It could be that the patients were bleeding and they needed blood, or sometimes it could be the other way around. But patients who are bleeding are obviously going to get more blood transfused at some centers. And they may or may not have to go to the OR. So it's just a matter of increased incidence as blood units increase, the reoperation for bleeding increases. Intraoperative blood usage with a mean of 27.09%. Is this at least one unit of any product? Yes, this is what this is what this question is answering is, was there an intraoperative blood transfusion? So that could be any product and any number of units. If a patient is on chronic hemodialysis, were they exempted from these slides? If they were on dialysis preoperatively, yes, they are not included in the renal failure metric. These are, and Jana's asking about patient status. Are these emergent cabbage only, or are emergent cabbage cases included? Yes, this is all isolated cabbage. And again, Carly, it's the same for postoperative blood. The average postoperative blood transfusion rate is 30.3%, and it's at least 1 unit of any product. And yes, Beth, the correlation could be reversed potentially. Patients who have more complications have a greater chance of getting a blood transfusion. That could correlate as well. And then Carla is clarifying, I mean, are we transferring to another acute care hospital?
And do you think, Carla, would you like to talk to us? I mean, was the answer unclear? Do you have further questions?
Can't see. If you want us to unmute you, Carla, will you raise your hand? All right. You can unmute yourself, Carla. There you go.
Thank you. Sorry, I have not abstracted for STS myself, and I just kind of manage over the registry that CARTA abstracts. So my manager had asked me that she was confused about, say we have a patient that, has a cabbage, gets transfusions post-operatively, but then they transfer out to another acute care facility because of whatever reason. Do we count the transfusions when we submit our data?
You would count the transfusions at your site plus the transfusions that happen at the other site. Because technically
Okay, so we would have to get the information from the other site to see how many total were given.
yeah, the important thing about transferring to another acute care hospital. So we're talking about acute care hospitals.
Right.
Is that you do your due diligence to collect as much data from that site as you can, because the patient's technically not discharged until he's discharged from that other acute care hospital. So a lot of sites who transfer patients frequently have probably developed some sort of process where they work with the medical record department at the other site to get those medical records, so they can fill in the blanks, the transfusions, the ICU hours, the complications that occurred there. So you do the best you can to get as much information as possible, because the discharge date that you actually enter in the STS data collection form is the discharge date that they leave the other acute care hospital.
Thank you so much. This helps me.
Okay, thanks. You're welcome.
I'm glad that was helpful. And Gloria is asking, how would you obtain the info on transfusions at another acute care hospital post-op?
I think, Gloria, most people work with medical record department to get the records from the other acute care hospital and have them sent over, and then the abstractor reviews those records for that information.
Thanks, Melinda. Lisa is asking about multi-valve. If a patient has an AVR, MVR, would this fall into the category of multivalve or other? Does this group of patients need cardiac rehab upon discharge?
I think so. One momento.
Yeah. So AVR, MVR does fall into multivalve.
That's true. One momento. My brain is very tired. I've been answering questions all morning, so I don't want to misspeak. Okay,
I do
let's
know
see.
that cardiac
Yes.
Okay.
Valve patients are required to have outpatient cardiac rehab along with CABG patients. So yes, you would want those patients to get an outpatient cardiac rehab referral.
All right. Thanks, Melinda.
You're welcome.
Beth, did you do a comparison using the risk? Were the higher risk score patients getting more blood? I did look at risk, Beth. I don't have a slide for that. I looked at that, and it was interesting that the risk did not correlate with blood usage. I can pull that together in a slide for next time if we want to see that. But intraoperative and postoperative blood in of itself did not correlate with the risk of morbidity and mortality when I mapped it out on a graph. Audrey, is it possible to find out where our program is on these slides? If you look at your Harvest 3 reports for isolated CABG, you'll be able to see on the benchmark report where you fall as far as your intra-op transfusion rate and your postoperative transfusion rate. And Beth, we did not correlate this data with any pump times or on pump or off pump status. And Lisa says, thank you, you're welcome. Val has a question not related to blood usage. So patient had a TVAR for a type B dissection. He went on to have a type A dissection requiring open repair. Can we count the type A as the index procedure since it's more extensive?
Well, Val, I need to know, can you talk to me? I need to know a little bit more about the timing. When did he have the type A? Was it post the type B? Was it a complication of the type B? Was this in the, just need a little more information. You want to raise your hand and speak to us?
Oh, here we go. All right, Val, you can unmute and.
Can you hear me now?
Yeah, we hear
Okay,
you.
hi. So the type B, the TVAR was on the 28th of January. And then the patient was still in-house and experienced endoleak and had to have the type A repair open.
So it sounds to me like this type A was a complication of type B or an extension of type B or something.
An extension of type B, I'm deducing from the notes.
Okay, so probably that would most likely need to be coded as a re-op aorta in the post-op event section.
Post-op event, okay.
Yeah, because
The surgeon just wanted to know if it could be entered as the index procedure, the second procedure. And I thought it would be a re-op comp. So I just wanted to clarify that.
Yeah, the cardiac surgeon did do the first T-bar, right? He was,
Yes.
yeah. So yeah,
Along with a vascular surgeon. There were two
yes,
co-surgeons.
yes. So that type B is your index procedure, and that type A sounds to me like it's a complication and would go in the post-op section.
Okay. Thank you so much.
You're welcome.
All right. And then Michelle is asking, was there a correlation between low pre-op platelets and blood usage? We did not correlate any lab values with this data. We were mainly just looking for volumes and transfusion rates and also complications. The slides are 3-year rolling correct. The STS report lists blood usage % by year. This is why I asked if it's possible to see where we land. So Audrey, this is Harvest 3. You're right. So on the benchmark report, it is by year, and this is a rolling year. So you might be able to get this on your participant dashboard. If you, Audrey, send me an email, I will help you figure this out if you want to email me offline. And Anne-Marie, this question is not related to the blood usage project, but do we have any update on when we can stop collecting data for beta blocker project? Thank you. No, we don't have any updates on the beta blocker project right now. We ask that if you're able, your site continue to collect that data for us. We do not have what we need to make an analysis on the beta blockers at this point. So if sites could please continue to collect that, we would be very appreciative, and we will let you know as soon as we have an update on that. No worries about the spelling, Michelle. And you're welcome, Audrey. All right. Looks like we have no more questions. Anyone on the panel have anything they want to add? Looks like Mary's asking, who do we contact regarding feedback on the audit company? Emily, can you take that?
Hi. Yeah, you can contact me, Emily Conrad, at econrad@sts.org, and I can also put it in the chat.
Thanks,
Thanks.
Emily. Mary says thank you.
Gosh, Nancy, I think this is the first time, and I can't remember when, that we actually finished before 1 o'clock.
I know.
Great
I can't
call,
believe
guys.
it. Thank you. If
Oh,
oops,
got another one.
got another one. Okay, Anne Marie. This question is not related to blood usage, but if a CT surgeon does not remove the pacer lead during the same procedure and inserts the pacemaker, do we include this case? Thank you.
Is that the only thing they're doing, Anne Marie? I mean, so do you want to talk to me?
Yeah. Raise your hand, Anne Marie, and we'll put you on the spotlight. All right, you can unmute.
Okay, can you hear me?
Yes.
Mhm.
Okay, great. Thank you. Yes, so this just came about today. So I know based on the eligibility criteria that if the cardiothoracic surgeon, removes pacer leads, that we are to include that case. But when we looked a little more into the documentation, it was a procedure performed with both cardiology and cardiothoracic surgery. And the prior pacer leads were actually removed by the cardiologist. And the new pacemaker was inserted by the cardiothoracic surgeon. So I did review the new eligibility document, and I was still a little bit confused since, they're co-surgeons, but the CT surgeon did not remove the leads, only inserted the pacemaker.
Yeah, you would want to include this. This is much like a TVAR. They're working together to do this case. They're both in the room. They're both there with the patient. I would include this one as a lead extraction.
Okay, thank you for the clarification.
You're welcome.
Appreciate it. Appreciate you.
Thank you.
Okay, Kim is asking for the multi-procedural composite coming with Harvest 1. Will this show mortality and morbidity? Yes. Mortality and morbidity will be risk adjusted for multi-procedural. All right. I guess everyone is busy getting their data together for Friday. No more questions. So I guess we will sign off for today. Thanks everyone for joining. Just sharing our contact information here on the slide. For any clinical questions, you can email STS-database-FAQ@sts.org. For any IQVIA database platform questions, and email the help desk. For billing and contracts and contacts, STS database@sts.org. And then I have my email there, Nancy Honeycutt, and Carol Crone. Her email is there as well. Please let us know how we can assist you. We value all of you so much. You're the best data managers ever. Thanks for joining today, and happy harvest.
Great call. Thanks, guys.
Bye, everybody.
Thanks,
Bye, everyone.
everyone.
Thank you
Great
all.
afternoon. Bye-bye.